I think I know most of you. I'm Jean Merchant. I'm a program manager at CCTS and with the Core. And it's my delight to introduce you to Dr. Monica Baskin. As you see, she's a professor of preventative medicine, the vice chair for culture and diversity. And she is a licensed psychologist, and her research focuses on minority health and health disparities. She's led an extensive extramurally funded research program using community-based participatory methods to reduce health disparities in the Deep South. And her work has been funded by the NIH, the CDC, Robert Wood Johnson Foundation, Community Foundation of Greater Birmingham, and others. And she's also part of the cohort of Robert Wood Johnson Foundation Culture of Health Leaders program. She serves in multiple leadership roles, focused on advancing health equity in Jefferson County, Alabama. And we are very lucky to have her here to speak to us today. Welcome, Dr. Baskin.
Well, good morning. Do the applause first. I can go sit down. Is there a reason why you all sit towards the back and not front?
The coffee's here.
Oh, I won't take it personally that you don't want to be close to me. So I'm delighted to come to talk to you guys this morning about one of my major passions. I think is really focused on stakeholder engagement, community engagement as we do our research. So I've got slides here. I'll present those. There should be plenty of time for questions at the end, but definitely feel free to stop me as we're going so that you can get the most out of the presentation and make sure that you have any questions that you have answered. So the typical disclosure, I'm going to talk a little bit about several projects that were funded by the National Cancer Institute, but the presentation contents are my own, don't necessarily reflect the NCI or NIH. So today I'm going to try to tackle these 4 questions. So what is stakeholder engagement? Why is it important? What does it really look like in practice? And then what are some of the challenges and opportunities should you choose to work in this kind of area? So first and foremost, stakeholder engagement. It's pretty simple. A stakeholder is a person or a group that has a vested interest in the clinical, research, or health policy decision. And therefore, stakeholder engagement then is a process of giving voice to those individuals who we're just mentioned as stakeholders, and making sure that they're involved in involving the stakeholders in effective healthcare related decision making and research, and it serves the purpose of reciprocal learning and knowledge exchange to improve health. So it's the idea of basically making sure that the individuals, the targets of your interventions, your research, are really part of the process as you're trying to decide how you develop the research protocols, how you create clinical guidelines, and so forth. So it's that process that really makes up what stakeholders and stakeholder engagement is all about. So I put this here just sort of to look at it maybe from a different approach in terms of the different levels of stakeholder engagement. So at the very basics, sort of thinking about a plant, you have stakeholders that provide input and assistance on recruitment, for example. So many of you, if you do any kind of community-based research, or even some of the work that you want to have eventually translated, you might ask, okay, how do we recruit subjects? You may go to people that look kind of like the folks that you're trying to recruit, and you just sort of ask that basic information. What can we do to increase recruitment? Another layer, a deeper level, then would be where you actually not only ask individuals or stakeholders about, how do I recruit, but you also ask them about input on the specific research question itself, the study design, and have active team members that are part of that process. And then sort of the most, the deepest level or the largest level here is about when you actually have academic stakeholder engagement relationships and you adhere to all the components of a community-based participatory research model. And that model I'll go over a little bit more. But essentially, any of these kinds of things would be considered stakeholder engagement. The difference is how much they are involved in all the aspects of the research. So then why is it important? So things might be obvious. So part of it is bridging cultural gaps. So many of you are probably very much aware that NIH and a lot of federal agencies have identified and documented over decades that not everyone is often included in some of the major research and medical trials. So it's really important to involve a diversity of individuals if we can be certain that the interventions, the medications, all of these things are really applicable across these different groups. And part of it is, whether or not individuals who are less represented in those trials or less represented in general, whether or not they actually understand and have an appreciation for what's going on, or they may have certain myths or beliefs that may not be consistent with them, participating in such a way. So having that involvement and engagement from the stakeholders can help to bridge some of the gaps that exist. It also helps to address community needs and or concerns. So sometimes, as researchers, we've got a great idea, somebody has said they're going to fund it, and we don't necessarily include or think about what the community is going to get or what the community needs. We're just really looking at the announcement, saying, okay, we can do this, and we move forward. Another reason why engagement is important is it may help correct or clarify misunderstandings. So if there is a misunderstanding about a specific drug agent or intervention, that people feel like, oh, this is not effective for women or for this group or that group. Part of that engagement is helping to educate the stakeholders that are involved, but also doing other outreach to other communities to make sure that there isn't such misunderstanding. Additional things that make it important, including improving the research. So we talked about the idea of trying to figure out how do you recruit. The study design itself could be improved. For example, if you decide to do a trial in which you identify, certain ways in which you want to collect information, and then you find out from your stakeholders that that's probably not appropriate, then you can actually change your study design or modify the design so that you can be more successful. It also helps with compliance in terms of giving people interventions that really they're not going to do. So having someone, for example, to eat only meals from a feeding study and not expect that, have them eating meals over, 30 days and not expect that at some point they may want to have something on their own. It also helps increase public confidence in the scientific integrity. So I'm sure you guys would be shocked to know that there are many outside of academia that don't necessarily put a lot of stock in sort of some of the research studies. So part of it is helping to build on the reputation of the science and the scientists that are doing this work, and also provide accountability. So there's nothing like having a community stakeholder on your projects to really let you know when you have not lived up to your promises or you're not doing something that's really important. So I think that's also a benefit. And probably really important for all of you and for anyone who's focused on translational research, having individuals who are from these stakeholder groups part of the process all the way through can potentially reduce the lag time between discovery and implementation. So anyone want to remember how long it takes from, typically on average, from a basic science type of research study to translation out into the communities? How long?
17 years.
17 years. So as the parent of an 18-year-old, basically, that's a long time between, and we've gone through many trials and tribulations in between that time. So that's a big deal. So when we're talking about taking what you're learning in your research studies, in your clinical trials, and getting it into the hands of individuals where it can benefit, one of the things you can do to help reduce that time is by making sure that what you're designing and what you're focusing on from the very beginning is something that people will uptake. So traditionally, many of us, if you had any kind of research, even as far back as maybe high school scientific method, this sort of traditional model is what many of us were taught and many of us actually practice. So it's, likening it here to a parachute model where you kind of come in today, you're gone tomorrow, you collect what you need to do, you go back to your offices, you analyze your data, you write up a paper, and hopefully you'll get enough reviewers to review it so that it can be published someplace. But the problem with that particular model when you're focusing on communities or stakeholders is that, again, there's limited, if any, attention to what the community needs. It's also limited or no immediate benefit. So coming in and collecting blood samples and buccal cells and all these different questionnaires, that may not have any immediate benefit to the individuals that you're working with. There's also a high potential for harm and distrust. There are many people that have gone forward in these kinds of settings, collected a lot of information, made a lot of promises, and then they've never been heard from before. So every successive person that comes afterward is having to actually deal with that disappointment or the issues of trust that might have been there before you. And then if you're thinking about interventions, there may or may not be any thought to how does that intervention continue when that 3-year, 4-year, 5-year grant is over. So this is a particular model that I'll pretty much spend the rest of the time talking about. So this is thinking about that last level of the stakeholder engagement, and that is community-based participatory research. So CBPR, really all it means is basically you're equitably involving all of your partners, so your investigators and your community members, and it recognizes the strengths that bring each part of that group together. So it's not just that individuals who are from the academic setting or the researchers have all the expertise and knowledge. It's also acknowledging that individuals in the community, while they may not have PhDs, MDs, MPHs, and so forth, and that type of knowledge, they certainly have doctoral level training in their community. And there are these
Would you mind talking about?
Sure.
I'm exercising your invitation.
Okay, yes.
Can you back off one more?
Oh, okay. Yes.
From this perspective, I know we're going to hear kind of the gold standard for what we should be doing, especially because UAB is well known in the nation and an expert in this field. And at the same time, if we have a med student, a nursing student, a social worker student, and so forth, who wants to do some of this, they should just do it, correct? With a mentorship and so forth. So the idea that they don't necessarily have the overall perspective should not preclude them from playing in this sandbox for 2 or 3 months, even though it's a touch and go. Your thoughts about that?
Yes. So, and I sort of smile a little bit. April and I think have talked about this before. So I would never encourage a student, probably not even a junior faculty member, to really take on CBPR and expect that their career will go along the trajectory that they want. It is really intensive, and as I go through and talk a little bit more about the principles and how it's been run, it takes a lot. But it's absolutely, something that I hope people would be excited about, getting connected with a group or a lab or some group that's already doing it, so that you can get the experience of what it looks like on the ground. But so certainly, medical students, graduate students, and so forth could be plugged in. But the steps that it takes to actually start building the trust and having someone engage, we're talking about months, if not years, to build those relationships. And that's not something you can kind of do in a couple of months. Sure. So then let's talk about why I would have, that's my personal bias in terms of not wanting, suggesting that people dive right into this if they're very junior in their careers. And it's largely because of these 9 principles. To really do the complete CBPR and adhere to these principles, you have to first recognize the community as a unit of identity. So most of our research, we're looking at individuals, not communities. But if you're doing CBPR, you're looking at what is the movement of the community, sort of a little bit more towards population health. You're really thinking about the larger goal here. The second is that it really builds on the strengths and resources within the community. So again, part of your decision making about what the research question is, how it's being designed, is you want to leverage what's already happening in the community that is a strength as opposed to a deficit. So oftentimes when we go into community work, we say, okay, this community has low income, they have high rates of high school dropouts. We have this, that, and the other. And so we're not really thinking about, well, what are the assets? So there's resiliency in those communities that still have these other deficits. The third is to facilitate collaborative and equitable partnerships in all phases of the research. This is one that is really difficult, particularly, I'll admit it's really hard even from an academic institution, because if you're really doing this, it's total equal partnership, meaning budgets. There's equitable relationships in the budget. And so inherently in the kind of research that I do and many of others, it's not quite equitable when the notice of award comes to UAB and not to the community organization. And so there are things that, I have done and my other colleagues will do to try to mitigate that, but it's certainly not the gold standard, if you will, of CBPR. The fourth is that it promotes co-learning and capacity building among all partners involved. So you have to have a stance as the researcher, investigator, that you have something to learn from this community as well. And so that is a bi-directional learning process between the two. It also integrates and creates a balance between knowledge generation. So yes, we want to get more publications, we want to get more grants, we want to rise in our rankings as a university. But, to do true CBPR, you also must be thinking about, well, how is that going to contribute to elevating and promoting and doing things in the community? The sixth principle is about making sure that you're emphasizing the local relevance. And this is where it also becomes really challenging for most of us when we're applying to research grants. So somebody has told us that there's an issue that they're willing to pay for, but we have to find and make sure that that issue is really relevant to the local community and not just a national issue. So that's really important, and part of that is having those conversations to say, what are the top 3 things that are really bothering you? And sometimes it's not what it is that the investigator is interested in. And so there's a dance back and forth to see how you can frame what it is that you're doing to sort of match the needs of the community and where there might be some overlap or compromise. The 7th principle involves is basically recognizing there's a cyclical and iterative process, which is something that really flies in the face of most of our research training. So this is the idea that you kind of get in the middle of things and you find information and then you might need to adjust. So most of us were trained, got a study design, you have a protocol, you do not shift from that protocol no matter what. But this CBPR means that you are responsive to things that you're learning and you have to make adjustments as you learn new information. The 8th part is making sure that you're disseminating findings to all partners. So it's not just getting the science, the Nature, the JAMA article published. You've got to make sure that your findings go back to the stakeholders in a variety of different ways. And then lastly is the long-term process and a commitment. I also often mention that prior to coming to UAB, I was at Emory in the School of Public Health and did a lot of CBPR research and made connections with people, and still almost 15 years later, some people are still reaching out and we have that relationship there. So it doesn't go away. And so I think the combination of all those things, really says that, in order to do true and adhere to all these principles, it really takes someone a little bit more senior in their career to sort of be able to manage all of these things at once. So I'll walk you through kind of how stakeholder engagement has happened in the work that I've been participating in as it relates to eliminating cancer disparities in the Deep South. So many of you might know cancer is the 2nd leading cause of death in the United States. Lifetime probability is about 40% if you're a male, about 38% if you're a female to have cancer in your lifetime. In this year, it's actually expected that 1.74 million new cancer cases will be diagnosed, so about 4,700 a day. And over 600,000 people will actually die from cancer this year, about 1,600 or so people per day. So clearly a significant issue and one that warrants a good deal of research and attention. But beyond the loss of life, cancer and cancer care is really expensive. So national expenditures in last year were estimated to be about $147 billion. And the 5-year survival rate for all cancers diagnosed between 2008 and 2014 was about 67%, which is really great improvement over the slightly less than 50% in 1975. But what do you think might be a challenge with that particular statistic from a public health standpoint? So it's good news that they're surviving, but
Doesn't say who's surviving.
Doesn't say who's surviving, and what else?
Disparities in terms of cost.
Have disparities in terms of cost. So these folks are surviving, but then they're also having other kinds of chronic conditions. So whereas individuals, they're surviving for a longer period of time, they may end up with cardiovascular disease as another issue. The longer they live, they may have other kinds of issues. And so the overall financial cost is going to continue to increase. And so if we don't pay attention to individuals who are surviving, who may also have a higher risk of cancer recurrence, then there are other costs associated with that as well. So the disparities, as someone was mentioning, is really something that the NCI has focused on for the last several decades. And they define cancer health disparities as basically any difference that exists between incidence, prevalence, mortality, or survivorship, where it puts a burden on certain groups rather than others. So it's a very broad definition of disparities, and one that I think warrants some attention, again, given that there is a differential rate of survivorship, there's a differential rate in terms of incidence along many different groups. So this is just an example of some of the cancer disparities that exist. So in spite of the fact that cancer prevalence for certain types of cancers is not higher among certain ethnic groups, the cancer mortality rates are pretty clearly linked in terms of those racial ethnic groups that typically have higher incidence of many types of chronic conditions. So for example, non-Hispanic Black men have the highest rates, cancer mortality rates, and non-Hispanic Black women as well. So the other type of disparity that I'll just kind of briefly mention is this idea of geography. And so individuals who are from rural areas may experience higher risks of cancer for a number of reasons. So limited health care facility access and other resources, limited transportation, sort of thinking about getting to care. Other lower income individuals who might not have the resources for preventive care or for other kinds of health behaviors. They may spend more time working, and why is that relevant?
Increase in stress.
Increase in stress might be one thing. Yes, what else?
They have less time to seek preventative care.
Have less time to seek preventive care. And particularly when you think about what the typical hours are for that health care, if you're spending a lot of time working or have late night shifts or early morning shifts, your actual availability to make an appointment between 8 and 4:30 when the health department might be open is much more limited. They focus primarily on treatment. So in a lot of the communities I worked on, if it's not obviously broken or bleeding out tremendously, then we're okay. We'll just kind of patch it up and keep moving. And there are higher rates of obesity and tobacco use typically in rural communities. Which brings me to the main crux of what I've been working on over the last several years is working with the Deep South Network for Cancer Control. So over almost 2 decades, this is a community-based participatory research project that focused on outreach, education, and research aimed at eliminating cancer disparities between African-American population in rural and urban areas in Alabama and Mississippi. So led by Dr. Ed Partridge, this is a partnership that has focused on Alabama and Mississippi, and they started off in the first 5 years of funding focusing on outreach and awareness. So using individuals who were considered to be community health advisors, they formed national and state and local partnerships, the American Cancer Society, the breast and cervical cancer early detection programs within Alabama and Mississippi, and the Medicare quality improvement groups in both of those states. And then they form local partnerships. So this is with civic organizations, with local governments, with local community-based and faith-based organizations, really getting people together to say, we're going to connect, we have common goals and a mission, and therefore we're going to unite together and focus on how we can provide outreach and education to get people to understand that early detection saves lives, and if we can get them into care, that would be so great. So the cornerstone was community health advisors as research partners. So these were individuals who lived in the local communities, who were already people that everyone would go to for advice. So these were, kind of the ladies, at church or in the PTA, or, the guys that hung around and would, play pool and so forth. These were all the people that people respected. And so basically they were becoming the link between the academic institution and sort of the messages we were trying to put out and the local community. And so they focus a large part on cancer awareness. So cancer awareness and screening messages that were targeted to these underserved communities. There were 8 key messages that were developed by an educational committee that was made up of stakeholders. And then probably over 1,500 community education activities with over 115,000 people were reached in that first 5-year funding cycle. And then NCI came back and said, great, you formed a nice academic community partnership. You've got local, state, and national partners. You've formed this network of 400, 500 different community health advisors across these 22 counties. Now let's see what you can do with that network in terms of delivering programs. So it went to community action planning and programs for the next 5-year cycle. So this included implementing a Walk Feel Alive program that originated here from the UAB Minority Health and Health Disparities Center. There were close to 1,900 members from 216 teams across these 2 states. All of the 22 counties were selected to implement this particular program, and they have volunteers who are our community health advisors, as research partners, our network partners who served as team leaders to motivate, encourage, and educate individuals around getting more physically active. And as you can see here, they were very active and stayed, so even up to half of them 2 years later were still part of their walking teams in their local communities. The other component of that 5-year cycle was doing interventions around diet. So 53 churches participated, over 2,500 participants, and this was NCI's dissemination project of 2 other previous trials that had gone on. The 2 were randomized clinical trials, both at UNC and at Emory. Interesting fact is I happened to have been on the research trial when I was at Emory, and then when I came over, realized that they had disseminated it with Body and Soul. So this is a church-based intervention where you focus on improving policies in the church level. So, modifying what's happening on Sunday dinners, including aspects of health and health promotion within sermons, putting up signage and so forth, and a peer counseling component where individual volunteers would call parishioners in sort of a motivational interviewing type style to encourage them to eat healthier. So these messages were included, and they intervened, and about 30% reduction in the number of people who reported no fruit and vegetable intake consumption was found 1.5 years after the program was implemented. And then the last component of that second 5 years was really about advocacy. So our stakeholders said loud and clear that they were tired of their the states, basically cutting funding to some of the early detection programs when they had learned from us that early detection saves lives, and they really wanted to do that and wanted to realize what was the way that they could be more active in ensuring that resources were available, particularly for individuals who were lower income in rural communities and didn't have great access. So the partnership with American Cancer Society was really great here because they already had an advocacy program, and they were able to work with our local stakeholders to make them aware of the power they have to impact the change in their health system. They identified opponents and champions and sponsors for the health issue, and started building relationships among people who were supporters. They focused on what was locally important to them, and would have actually days when individuals would go with their branded T-shirts and so forth, and logos for Deep South Network, and actually go to the state legislature and have days where they would go around and talk about what these programs meant to them, and would really show up in force, as well as do letter writing and phone calling campaigns as well. So they really built grassroots and legislative support for statewide smoke-free workplace laws. They increased tobacco tax in Mississippi, and at least a couple of those years, they were able to maintain a certain level of funding here in Alabama for the breast early detection programs. So one of the things that was sort of published around the end of that second year cycle was this data here. So when the Deep South Network started around 2000, what they realized was that there was a significant disparity in Medicare mammography screening rates in Alabama. So thinking about mammograms, individuals who are eligible for Medicare, it is covered. So it's not an issue of cost, so sort of can't afford it. So the disparity was one that we thought was actionable in terms of getting people aware of the fact that it is a part of your benefits. If you have Medicare, you can get that. And over the course of prior to the start of the network until, slightly before the end of the second 5-year cycle, the disparity actually was totally eliminated. So that's great. So we built a network, we showed we could do some programs, and then the last 5 year, or I guess it was technically 6 or 7 years for no cost extension, funding from NCI was right when the NCI director was changing, and there was really a sense that these networks needed to show that they could have impact in a different way, that they could do randomized trials and show what could happen with these networks. And so that's where I think we went back to our stakeholders and we mentioned what was going on, that it was quite different than the previous cycles that we had of funding. And it was right around the time that there was a lot of lay press around the links between cancer and obesity. So basically half of the top 10 cancers, common cancers, were really associated with excess weight. And so that was known by our stakeholders, and they really urged us, okay, what can we do about this? We also knew that healthy diet can help sustain a healthy weight and lower risk of cancer, and that physical activity, even separately from weight loss, could also independently lower the risk of cancer. We also knew that 2 of the states that we work in were part of the states with the largest percentage of individuals who self-reported obesity. And so it's really timely for us to think about that within Alabama and Mississippi. And then more specifically, thinking about in the Deep South. So this paper that came out by the CDC showed that non-Hispanic Black women in particular had higher rates of obesity among the individuals in the Deep South region. So taken together, we sort of had an idea about focusing in the Deep South around weight loss and weight management as a way to prevent cancer. And we then decided on the full research project that went under this U54, which was Journey to Better Health. So I'll pause here just to say a couple of things about this. So we, thinking about the steps, we really thought about what's going to be important for the community itself. We also thought about, what was the local issue. And while we got some pushback from the African-American men in our group about why we were focusing on African-American women, we had conversations about that. And we also looked at the societal context in the Deep South, which is one where women, on average, or typically, are the ones that are responsible for purchasing and preparing foods for the entire family. So we basically talked about, yes, we will start by intervening with women, but potentially they will have impact throughout the whole family. And therefore, our other stakeholders, male stakeholders, were able to get on board. But what do you think about this particular title? How did we arrive at Journey to Better Health when we're talking about a randomized trial around evidence-based weight loss interventions?
So are you trying to get sort of blessing and approval? Or
No. What do you think about it? I mean, why do you think we arrived at this title for the intervention? Why didn't we call it weight loss trial? Why didn't we call it, what is it? Cancer prevention trial.
Because there's a process.
Go ahead.
Oh, because there's a process
Okay.
of getting there?
Process of getting there, yes.
So it could introduce bias if you called it what you were looking for.
Okay, so possibly biasing them. What else?
Multiple positive effects from weight loss.
Multiple positives, so not just weight loss.
It's person-centered.
Okay. Yeah.
Probably your stakeholders. That's something you
Yes, and so Stakeholder definitely created the name, and we found a logo to match, but it was based on the things that you're talking about. So the idea, what we were told is that do not put weight loss in that title. Do not have it about weight loss. We don't want to get to a certain size, and when people talk about weight in the larger lay community, they're really talking about, particularly African American women will say, oh, I don't want to be a size 0. I don't want to be a size 2. So I don't want it to be about weight loss. That's offensive to me. They also talked about, so for the idea of a process, that this is not, a magic pill. This is not all those different things that you see on infomercials that, you just wear this for 6 months and then you're good. They knew that it was a struggle. This is not like the women that we were targeting didn't realize that they had excess weight and they hadn't been trying to do something about it. It really takes a long time. So they didn't want us to also, bias anybody to say, okay, well, I'm not going to show up. So the journey represented the process and the fact that it's a lifelong kind of an issue around managing your weight, getting healthy diet, and having regular physical activity. And that, yes, this could help with the prevention of cancer, but it also can help prevention of diabetes, of cardiovascular disease, other kinds of conditions that this stakeholder group recognized were much more of a burden for African American populations and particularly individuals in rural areas. So all of that went into the decision making around how we named and labeled the intervention. So I'll start off, first of all, just acknowledging this was a huge team in which we focused for 5 years on this trial within the U54. Lots of people in terms of investigators. We had junior investigators and trainees that were part of the study. And then we had, local individuals that were hired in their local communities but became UAB employees. And I'll come back to that later on about why that was really critical. So let's talk about the study design. So it was a 2-year cluster randomized trial with, we used 8 of the 22 counties to be a part of the trial. It was overweight African American women in these 8 rural counties in Alabama and Mississippi. So you were randomized either to the 24-month weight loss program or the 24-month weight loss program plus community strategies. What's wrong with this design?
It's not a true clinical study because the control group has an intervention.
So it's not our typical gold standard where if somebody gets something, somebody gets nothing, and we compare it. So absolutely. So why do you think we did that? Besides the fact that I'm not a good researcher. But what else? Why would we have done it? The answer is always stakeholder engagement, right? So, but go ahead. What were you going to say?
I was just gonna say, so everybody that participated would get something from it.
Yes. And why is that important?
Fosters trust.
Fosters trust, and keep in mind that this was in the same network that for 10 years we had been involved and connected with people. We had been telling them about prevention and saving lives. We had also been telling them about the links between obesity and cancer. And what our constituents, our stakeholders said is that you can't tell me that there's a link between obesity, nutrition, and physical activity and cancer, and that there are evidence-based programs to help reduce that risk, and then tell us we might randomly get to something where we don't have anything. So this was not just bad researchers and study design. This was intentional. And it was one thing that I think we were all quite anxious about going through the review. But fortunately, the reviewers saw our point, and we were funded. And I was particularly excited because this was the section of the grant that really made it or broke it, and I was the one who wrote it. So, but what we did, we listened to our constituents who said, we want to have an intervention. And so we did it still was a cluster randomized trial led by, very well established study design experts here. We did everything else and it was randomized, but we chose to have an intervention or have interventions in both sides. So more of a pragmatic kind of a trial. So the behavioral weight loss program was adapted from 2 different types of behavioral trials. So the weight loss maintenance trial and the premier trial, which is based on the DASH diet, both of which have had other large amounts or percentages of African Americans in them. And we trained our local staff and volunteers to actually deliver it. So unlike those randomized trials that I mentioned that were delivered by psychologists and dietitians and nurse practitioners and so forth, our particular study design involved using those same community health advisors and other local individuals who, again, were paid by UAB or UAB employees, but they remained and lived within their community. The community strategies were also selected from evidence-based models. So this was when CDC came out a few years back with these particular models about what you can do at the community level to actually improve and address weight loss. So we started off in thinking about how we design and figure out how we implement this study. We started off by looking at the nutrition environment. And so we use a participatory process here where we looked at each of those 8 communities. We gave community stakeholders cameras to do a photo voice project where they took pictures of things in their local community that were either supportive of a healthy diet or were sort of barriers to the healthy diet. We also then trained local volunteers to go into grocery stores and other food stores to basically assess what was available in those communities. So, healthier meals and food products and the pricing and so forth. So we wanted them to get a sense of what their nutritional environment was about. And then there's the physical activity environment, the same thing. So we took pictures of the physical activity environment about what was helpful, what was not helpful in terms of getting physically active. And then we also utilize a surveillance tool to go and look through to see which things were there. Again, all collected by the stakeholders. And then that information for half of the group was used to help develop their community strategy. So we gave funding to local applicants to do something at the community level to help support the weight loss. So we awarded these mini grants across those 4 counties. So they did things like they expanded their farmers markets and community gardens. They used extra incentives at farmers markets so that people could buy more produce. They did park improvements, indoor walking trails, all of those things at the community level that they felt would be supportive. And they basically chose from a menu of things out of that CDC guidance that we had shown. But they used the data that they collected, that they analyzed, to be able to determine which were the things that their community, their local community, needed to help support them. So the behavioral intervention is your typical one. It's sort of 3-phase. The first 6 months is the most intensive. Face-to-face meetings, again, led by someone who was in the region, so the Black Belt of Alabama, the Mississippi Delta, and their local coordinators, along with the volunteers. Original goal of weight loss of 5 to 10%, sort of the typical behavioral weight loss. Come to sessions, track what you're eating, get physical activity, so on and so forth. Nothing really, innovative about it because these were evidence-based programs. And then over the next 2 phases is basically phasing them to less interaction. So the next group after that first 6 months is really interaction a couple of times a month, then monthly. This time it's only led by the local person who's hired there and the volunteers, and eventually moving to the 3rd phase, the last year, or the second of the 2 years, to being totally by phone, only by volunteers, and really to kind of motivate people to kind of keep up the good work or to revisit along this journey what they needed to do. These are sort of the 20 different intervention sessions. Again, the typical behavioral ones, focusing on, making sure people understand about how do you count calories, what's the importance of, having regular physical activities, how do you sort of plan ahead, how do you budget your time, how do you manage stress, and how do you basically deal with those unexpected kinds of things that happen, like celebrations or people in the workplace that are bringing in donuts to celebrate in the morning. It was a manualized intervention, so we had manuals for both the interventionist, but also handouts for the participant. They had a progress report that they would get periodically that would show their progress towards meeting their goals with an inspirational, tailored message, depending on where they were with their own goal setting. They also had an incentive program so that if they followed those 5 key steps to increasing or weight loss, like coming to sessions and monitoring what they were eating and so forth, they got certain miles. So again, feeding off of the theme around a journey. They got so many points, which were miles, and then after you get certain amount of miles, then you can redeem those for other kinds of goodies that people like to get, all these different trinkets. So we targeted 400 overweight and obese African American women from these counties. The local staff went through and initially screened 920 women who met our the basic eligibility. Of those, we went back and had a phone screen, looked at some other medical history. 494 of those women then were thought to be potentially eligible and were invited to the baseline, which was the full assessment for confirming enrollment, in which 409 women did enroll in the trial. I just list this here just to say that the communities that we were working in are ones in which there are comorbid conditions. So it's not just individuals who are overweight and obese. This is a group of 85 women that we had to turn away from the study because they had uncontrolled diabetes or uncontrolled high blood pressure. And because of the fact that we were intervening within local communities and not here in Birmingham, the issue was really around safety. We didn't have someone for them to go. They were here locally. We could probably manage this a little bit differently. But this also caused a great deal of discussion, I'll say, both among our investigators and our community members, because people who have problems with their diabetes and hypertension are the very ones that you want to be losing weight. But this caused a lot of debate, I think, and we were very torn with this, but we ended up with still excluding those individuals. So this is a population that was clearly lower income overall, but one of the things that I always put here, and people ask me if this is correct, these are folks who have much higher education. And why? What do you think is the difference here? Why is there a discrepancy between income and their educational attainment? And I mean, there's no real answer, but what might be some hypotheses?
So is that family income or individuals' income?
It's household income. Job availability. What else?
They may be older and closer to retirement age.
They're mid-40s, so being in this range, I don't know that I want to say that they're older. But yeah, they could be close to retirement. The other thing that comes into play here in many of the communities we've worked in is that there might be some disparities in terms of what people get paid. And so individuals in this area, even though they have a certain level of education, their value to those companies and what they're actually getting paid is a little bit different. So we do know that historically African Americans and folks in some of the lower income communities tend to have lower wages, and not necessarily because the titles are different. So there may be potentially discrimination there. The other issue is that the educational training may not be uniform across. So what might constitute a college degree and a certain level of training in one institution may not carry forward. So the types of skill sets that might land people in jobs that may be higher paying may not be there. But I also mentioned to people about this is one of the reasons why there's a risk when you use only one socio-demographic variable to sort of identify your sample. If we only look at income, we would miss the fact that these are folks who are typically considered to be more well-educated. So we had great retention overall. Almost everybody stayed in at 6 months of the trial, and again 1 year and 18 months later, and even at the 2-year mark, we had close to 75% overall that were still enrolled. And so here's the main thing that I'll mention. So what we were able to find in the most intensive piece of the application, of the study, was that both groups tended to lose weight. And there was statistically significant weight loss among both groups that sort of averaged around a 2.7 kilogram change. So we didn't find differences between the two. So our randomized trial where either you had the intervention group or you didn't, or you had the intervention group but plus the community strategies. But overall, people did lose weight. And in addition, they did have improvements in blood pressure, cholesterol, and triglycerides across the entire sample. Yes.
The weight loss was for 2 years?
This is the first initial 6 months weight loss. So, and basically, with that, we felt like some of the successes where we showed, yes, you can use the CBPR method reach a significantly reach a hard to reach target population. It might suggest improvements in health outcomes that may be clinically meaningful, and that trained health staff and volunteers delivered the translation and got about the same level of weight loss as other weight loss trials. So on average, African Americans in each of those trials lost about 2.7 to 2.9 kilograms in that first 6 months. Not stellar in terms of weight loss, but still it's about the same. So if we're thinking about communities that don't have access, then certainly it's probably going to be a lot easier to train local individuals to deliver a program like this than it is to get, nurses and doctors and psychologists and nutritionists shipped in basically to these communities to deliver the program. So, and as I conclude, basically there are ongoing challenges, I think, with this type of research. So there's a continuum here as you think about on the far right is a community-driven research project. So your stakeholders are really driving what you do, how you do it totally. And at the other end, it's, the investigator. We are driving everything. We know everything. We're going to make it happen. And somewhere in between is this participatory research where you have this balance between recognizing the expertise on both ends of that spectrum. And we certainly felt it in a paper we published about what it was like to go from 2000 to 2017 and basically shift this network from doing outreach and awareness to doing a randomized trial and some of the pitfalls and challenges that we found in shifting that across in that balance. Costs are really expensive. So you saw the acknowledgement, that was a lot of people to put on this particular intervention. Staff training and supervision. So these were UAB employees, so they had to go through IRB training, other kinds of things. And we were literally hours away from staff. So the kind of oversight that may be typical when you have somebody who's, in the next office or down the hall, it just cannot be there. Maintaining funding beyond the randomized clinical trial is also a challenge here. So probably in our fourth year of our 5 years of funding, NCI decided they were discontinuing this long-standing program. They were no longer going to do these academic community partnerships. And that was a big blow to this, for almost 2 decades, people had been used to this kind of work. So they gave some extension money for a year or two so we can get our act together. But still, that was very devastating about what you do with these programs afterwards. And then translating findings for community members. So yes, we've gotten multiple publications. We plan to continue to do more, but that's really, really difficult. Yeah.
Look, you made a very interesting point earlier in the principles of CBPR about having the money flow directly to the community and to community organizations. I wonder if you could elaborate on that in the context of this study and other ones that you've done. I guess the practical challenges to it, I'm kind of perseverating around thinking about what that looks like with all the bureaucracy that we have with some of these grants, and particularly the potential concern that as groups in the community become more organized, are they really as grassroots? And we've had this problem with PCORI where we've worked with patient advocacy organizations. They say, well, that's great, but they're really not the patients. They're these organized groups of professional patients. And so how do you really keep it at the grassroots level? And do you end up then paying people as consultants rather than paying this super organized group of people that really has become more professional and less potentially representative of the true community?
Yeah, so it is extremely difficult. And that's why I say that even the work that we've done is probably not adhering to all those principles. So what we've done, both in what we did in this trial and my own other work, is when there is an agency that we can fund directly, we do a subcontract with that group. They have to follow all of because it's federal money, they've got to have all the assurances and so forth. And we've been able to negotiate very painstakingly with accounting to how we fix up those contracts. One of the things that we ran into this project with their mini grants is that what UAB typically does is they want you to expend the money and then get reimbursed. We went as high as we could, and we got them to change that sort of process where we were able to issue out money because these were not organizations that had money laying around. So we were able to get and assign contracts where that could happen. So I think that can happen, that, when there is an organization and they have a 501c3, when you can directly give them a charge and a contract where you lay out exactly what they're supposed to do, their scope of work. They had progress reports they had to submit in order to get the next installment. That's ideal. So the piece of the grassroots it's really difficult. I mean, I don't know that I have the answer. I think for the groups that we work with, it's not been so much that they want it to be an entity to go after this. And in fact, one of our original grantees ended up giving us the money back because they felt like they were too constrained. They didn't want to fill out all the progress reports and so forth. And so they gave us the money back, and we had to then go scramble and award the next project down. So it is difficult to do. But I mean, I think you can put in parameters to say, yes, you need someone at the administrative level to kind of handle the money and do the logistics, but that the board or the membership itself should be made up of individuals who are grassroots. But it is a challenge. It is, again, part of that continuum of trying to remain true to the grassroots, but also your hands are tied because UAB won't issue out money unless you have some kind of organization. So the last thing, opportunity. So I think CBPR has definitely come of age at NIH. There have been many, many more grants and RFAs that have been out since I started, even 15 years ago here at UAB when I wanted to kind of do these things. So there's a lot more out there. Peer-reviewed journals actually are also stepping up to the plate and recognizing that there's some qualitative and process type papers that talk about these kinds of things. And so I think that's great. There's still a lot to be done. So for many of you in this room, we don't have a lot of cost benefit or cost effectiveness evaluations on these kinds of trials. So I mentioned it was very expensive. We possibly or probably got some clinically significant difference, but we don't know when that pans out whether or not that actually there was any cost benefit to that particular trial if you try to ramp that up. And then certainly dissemination and implementation science. So yes, we've shown that you can do it with lay individuals. What my next R01 is about is really trying to take that out and disseminate it more widely so that we can get that out to more individuals. So again, CBPR I think is a marathon. It's not a sprint. It's not for the faint of heart. It's really recognizing that you're co-learners in this process, and mutual trust and respect are really, I think, essential to the success. Other questions or comments? Yeah.
So your trial design is really interesting because your baseline was individual targeted and the intervention was community targeted. So I was wondering if you were able to look at the impact of the intervention on the broader community in addition to your trial participants?
So we are we've got tons of information. So we're looking at, we did have baseline at the county level because the way the network is by county. So the 8 communities were matched on county sort of demographics for one, and then they went into and were paired and then were randomized based on that pairing. So we've have some information largely on a qualitative basis, but to sort of evaluate at the community level what's happening. The difficulty there is, how to measure. There aren't really great community measures. So I'm part of a group at NCI that's looking at how do you do multi-level, how do you evaluate multi-level interventions, and it is really challenging. So that part of the science and the research has not yet caught up with interventions like this where you're trying to intervene on multiple levels.